Introductions. So I will start with Representative Matheson.
Good morning. My name is Christy Matheson. I represent Kittery, District 1.
And Representative Arford. You're muted still, Representative Arford.
Yeah, there were a line went across, just so you know, a line went across my mute button. So Representative Poppy Arford, District 49 in Brunswick.
Thank you, Representative Arford. And Representative Quint.
I'm Tracy Quinn. I represent House District 144, which is the Greater Holton area.
Thank you. And Representative Evans.
Hi, I'm Representative Richard Evans. I represent District 120, Dover, Foxcroft, and surrounding communities.
Representative Brooks.
Good morning. My name is Heidi Brooks. I represent District 61, part of Lewiston.
Representative Melorano.
Good morning, everyone. My name is Gina Melorano. I represent District 62, which is part of Auburn.
And Representative Morris.
Good morning. I'm Representative Joshua Morris. I represent the towns of Turner, Leeds, and Livermore, where there are no mosquitoes today.
Thank you very much, Representative Morris. I'm not surprised. I'm sorry, I made a mistake. I should have called Representative Blyer before you, Representative Morris. I apologize, but Representative Blyer.
Thank you, Madam Chair. I'm Mark Blyer. I represent District 22, which is Leamington, part of Buxton, Standish, and Limerick.
And Senator Brenner.
Good morning, Madam Chair. Thank you so much. It's nice to see everyone. I'm Senator Stacey Brenner from Scarborough, and I represent Senate District 30, which includes my hometown, as well as Gorham and part of Buxton. Thank you.
And Senator Stewart.
Good morning, everyone. I'm Trace Stewart, State Senator in District 251 communities in Southern Aroostook and Northern Penobscot, including the town of Ludlow. And it is a very windy day in Aroostook County is how I would classify it today. I'm sure Representative Quint is experiencing the same down in Holton.
I believe Representative Quint is in Augusta.
I stand corrected, Madam Chair.
But Senator Sanborn, I wasn't sure you were going to be with us this morning. Welcome.
Good morning. My name is Heather Sanborn. I represent Senate District 28, which is half of Portland and half of Westbrook, but I'm coming to you live from the couch in Carrabassett Valley at Sugarloaf, where it is far too windy to ski. And so I am here. We just had the largest gust of wind I've ever seen here, which is saying something. It picked up a metal fire pit and threw it across the backyard. So needless to say, I'm not skiing and I'm here with all of you to learn about the budget today. So
thank you, Senator. And I am Representative Denise Tepler, House District number 54. I serve as the House Chair of the committee, and Senator Sanborn serves as the Senate Chair. We are joined today by our clerk, Christian Ricci, big Christian, and our analyst, Colleen McCarthy-Reed, who will give us the overview of the budget hearing that we're going to be having with AFA in about an hour, 2 hours, almost 2 hours. So please go ahead, Colleen.
Sure, great. Thank you. First off, I hope everybody received the updated budget documents. My apologies for the mix-up in some of the documents were from the previous biennial budget. So we got the documents updated for you, and I emailed them, and you should be able to, I'll be sharing them in just a minute. But But I think as Representative Tepler and Senator Sanborn mentioned, we're scheduled to have a joint public hearing with the Appropriations Committee starting at 1 on the biennial budget areas that are within the HCIFS committee's jurisdiction. And so they have scheduled that to begin at 1, and they have provided some documents. And so I just thought it would be a good opportunity to quickly go over them and kind of orient you to them. As part of the process, the committee will have the joint public hearing with the Appropriations Committee today, and then they ask each policy committee to then meet and have work sessions to discuss and make recommendations back to them on each of the initiatives within the biennial budget. So we'll be starting that on Thursday, and hopefully we'll be able to complete that and get a report back to the Appropriations Committee by March 12th. That's the deadline that they have asked our committee to adhere to get some written recommendations back to them. And we'll use a similar process to what we did when we talked about the few items in the supplemental budget. We'll have straw polls, and we'll put together a written sort of memo back to the Appropriations Committee with the committee's recommendations. One housekeeping thing, I just wanted to double check and make sure everybody did receive the Zoom link from the AFA committee this morning. I think it was sent out about 8:30. So you will have to jump off of this Zoom and use that link to access the joint public hearing with the Appropriations Committee. And then following the public hearing, we'll be coming back and meeting as a committee, hopefully starting at 2, to work on 3 bills this afternoon. So you will have to jump between a couple of Zooms, but looks like everybody received the link, and let Christian or me know if you have some issues. You can also contact the Appropriations Committee directly. It is a panelist link, so they are unique to each individual person, although if you can use someone else's link to get in and then rename yourself, you'll be able to do that as well. So 2 things I wanted to share with you really quickly. And I'll do that now before we start. I guess I'll go straight to the I wanted to show you one thing on the appropriations Appropriations Committee website that might be useful to you as you're navigating the budget, or if you're interested in any particular information related to the budget. They do have a number of links here, so you'll be able to, if you're interested in other areas of the budget or our own, you'll see they've linked to the particular schedule for today on the website. And then as the committees move forward and start making their recommendations to the Appropriations Committee, you'll see that they'll add the materials and add each of the individual committees' written report backs to them with regard to the biennial budget. So this will be an ongoing process, and that'll be added to their website. But it's, if you're interested in sort of general budget information, not only about the HCIFS committee, but some of your other committees, this is a source of that information. And then I also wanted to show you that the, we talked about this briefly at the orientation time, but the Office of Fiscal and Program Review has a handy overview of the budget process that you can access on their website. And it just provides sort of a general description of the budget in the budget format. It also has a nice glossary of terms at the end, if you're interested in some of the particulars about some of the unique terms that we use to refer to the budget. And I'll go over some of those as we go through our particular budget documents, but I just wanted to let you know that those 2 additional pieces of information are available to you. And then I'll just quickly pull up our own budget documents and give you a quick run through of the documents. I won't take a whole lot of time. I know so you'll be able to have a full lunch break and time for any caucuses that you might have this afternoon. But I wanted to just show you these budget documents. And so the first page really just kind of gives you a sense of the different programs within state government that are under the policy oversight of the HCIFS committee. So the first item relates to the administration of employee benefit plans, particularly the health insurance programs within the Department of Administrative and Financial Services. So the accident, sickness, health insurance account and the trade adjustment assistance health insurance accounts are those that deal with the administration and oversight of the health programs that are available both to state employees and retirees. And there's a piece within the Dirigo Health that particularly for the Maine Quality Forum, which you've heard a lot about, the Maine Health Data Organization, and then under the Department of Professional Financial Regulation, each of those agencies are listed here. And I see a hand. So please interrupt me as we go through. Happy to do that.
Madam Chair, is it okay if I do?
Yes, Senator Sanborn, please proceed. And Colleen, in general, is it okay if committee members interrupt you?
Absolutely.
Okay.
Great. So, Colleen, in light of the news this morning or last night that Maine Public broke about the licensure of mental health providers, I'm interested in the fact that I suspect there's a residual budget of the DPFR that accounts for the licensing boards that don't have separate budgets.
Yes.
And I'm curious as to the level of detail that we have about whether those budgets are underfunded, whether they're moving money from one profession to another, those types of issues. And then also as to the level of staffing that they have and whether those budgets have been swept in recent years.
Yep.
So if you wouldn't mind pulling some more of those pages for us, I recognize those aren't the ones that were identified as being within our jurisdiction, but they certainly are.
Yes.
When it comes to any other sort of healthcare provider other than the ones that have their separate licensing boards.
Right. Yeah, I was going to mention that. The Department of Professional and Financial Regulation, their Office of Professional and Occupational Regulation, which has oversight for the licensing boards that are under the jurisdiction of the Department of Professional Financial Regulation. While there are some licensing boards that are health related that are overseen and administered through that office, the budget for that office is overseen by the IDEA committee, but I can definitely pull some of that information for you. And hopefully we'll be able to get some specific follow-up information on the issues raised by that NPR report from the department as well. But I can also go back and track some of the history of the transfers and see and get that information for you.
Yeah, that would be great. If Lauren can help us with understanding what's been swept and when, that would be great. And just, I'm sorry, the committee, just to let everybody know in case they missed it, there was a report that it's taking like up to 7 months to get licensed as a mental health provider right now in the state of Maine, during a time when we have a massive provider shortage. This is the type of thing we've heard in a number of different licensing situations over the couple of years we've had jurisdiction here, but this one seems particularly acute. And the providers just wrote a letter to the Attorney General requesting relief. So this is going to be something that we want to immediately follow up on with Commissioner Head. And we have the opportunity to do so in the form of the budget.
Yep. And I think they will be providing that information. I had a brief conversation with them this morning, so hopefully they'll be able to follow up soon. I'm trying to go back and track.
And it's the Board of Counseling Professionals, I believe, that is in question.
Yes, I think that was the particular board. I know that sort of all of the licensing boards have been dealing with, as a result of the governor's executive order back in March, they've been permitted to issue emergency licenses. And so they have been doing that. And I don't know if there's some interplay between the issuance of emergency licenses versus the issuance of sort of full licenses. And so they're trying to sort of get to the bottom of some of the issues that were raised in the letter. So hopefully we'll be able to get some follow-up for all of you shortly.
Thank you, Colleen.
Mm-hmm.
And are you all set then, Senator Sanborn?
Yeah.
I think this is a big concern that our committee will want to perhaps raise with AFA as well, if we have the opportunity to do so.
Yeah,
Perhaps in our letter, if not
right.
verbally in the hearing today.
Yep. I
Right.
think,
We can
yeah,
make it part of our report back.
most definitely. Sure. Yep. So in addition to, we just touched on one office within the Department of Professional and Financial Regulation, but HCIFS has oversight over the Bureau of Consumer Credit Protection, the Bureau of Financial Institutions, the Bureau of Insurance, and the Office of Securities. And then there are sort of the independent affiliated health licensing boards that are also included that have sort of separate budgets. The Board of Dental Practice, the Board of Licensure Medicine, the Board of Nursing, the Board of Optometry, and the Board of Osteopathic Licensure. So all of the documents are included within here. And then lastly, I did also include for you this last page, which might be of interest to you. This is within the Department of Health and Human Services, but this page relates to the budget for the creation and establishment of the state-based marketplace that we talked about last time. And there is a piece of the budget that authorizes certain positions and reflects the federal funding that comes in to support the administrative costs of that. And that's on the last page of this budget here. It won't be the subject of your budget hearing today, but I just wanted to include it as it might be of interest to you. There are no new initiatives related to the health insurance marketplace, it would just continue with their current level of funding. And then you'll see they do receive their funding from other special revenue funds, which is not the general fund, obviously. And that comes as part of administrative user fees for those people who are enrolled in the marketplace. A portion of their premium comes back to the federal government for running the healthcare.gov platform, but the state is receiving some money now because they've taken oversight over the consumer outreach and education pieces. And then as the state transitions to a fully state-based marketplace using the federal platform, there'll be an opportunity for some increased funding from those user fees coming back to the state. So that's just really there for your interest.
Colleen,
But yes.
I think it's important for new members to understand the difference between initiatives and the parts of the budget that have no initiatives.
Right. Yep. So I was going to, for an example, I guess I'll go to the Maine Health Data Organization as one example, just to kind of orient you through to the budget documents. So you'll see and kind of try to explain what Representative Tepler was talking about. So you'll see at the top is really just a summary of the funding for the departments, and you'll see the actual and current is reflects their current budget, and then the budgeted amounts for 2021 and 2022 and 2022 and 2023 are the proposed spending amounts in the biennial budget, so that we are reviewing. And the budget document does describe each agency, and then you'll see under this the language sort of what the budget purchases, just talks about, gives you a brief summary of the program or the agency and what it does. And then if you look down at here where you're talking about the program funding, so the Maine Health Data Organization is an agency that receives all of its funding through assessments and fees on the entities that report to it. So it receives its funding from other special revenue funds. If you'll see other budget documents will reflect that other agencies will receive their funding from the general fund. And so, but here they're receiving their funding from other special revenue funds. It'll give you a position. So the legislative count line is the number of authorized full-time equivalent positions that are within the MHDO. And right now they have 6 budgeted positions. The personal services line reflects the budgeted amounts for salary and benefits. And you'll see here, you'll see the current amount, and then you'll see a slight adjustments budgeted in each year of the biennium. So the personal services line does have an adjustment built into the budget for any sort of planned increases related to salary and benefits. And then the all other line would encompass their spending on general operating expenses like rent, travel, any contracts that they would be allowed to spend money on, and that's the all other line. And then you'll see any adjustments. Oh, sure.
Sorry, Colleen, I just want to go back to the personnel services line and point out that the budgeted amount for 2021-22 is less than the current spending for personnel services. And some of that may reflect savings in health insurance, but it also may reflect the fact that they did not do their checking up on the health institutions in regards to infection rates, but I don't know. And that's something we may want to ask about, just recognizing that it's a decrease. And if it's just related to health insurance, that's great, but 20,000, I don't know that we're coming down that much in health insurance.
It may reflect to some period of vacant positions as well, from what I understand. And so that's something that you can definitely, those are the things to kind of pay attention to, and you can ask for follow-up information. So the initiative piece in each budget document, here is where you'll see if there are any proposed adjustments to the baseline budget, which is sort of what's projected up here in the program summary. You'll see a description of what that initiative is here. With MHDO, they're not making any proposed changes either up or down to their existing budget. So you'll just see again and then the revised program summary would incorporate any of those adjustments or initiatives for the final total. So that's an example of an agency where the biennial budget does not propose any adjustments. They're just proposing essentially that they maintain operations at the status quo for the next 2 years of the biennial budget. There is a piece related to MHDO in the language of the budget, which is here, part DD, which I wanted to point out to you, which would, if it moves forward, authorize the MHDO to transfer some of their balances up to $325,000 that might be available in their personal services allocations to their all other line category. This is something that's been done in the past, and I think it's been done to reflect the additional contracting work that MHDO does for some of its data collection and reporting efforts. So, and you'll hear more about that this afternoon from the agency as to why this language piece is included as proposed in the budget.
I think also that we've had them hold a couple of positions in a hope that they could eventually be able to do some of their own analysis, but meanwhile they're contracting some of that analysis. I'm sorry.
That is true. Okay. So the next one I wanted to show you is, this is an example from the Bureau of Consumer Credit Protection, just taking it for an example, but this will show you where there are proposals in the biennial budget for making some adjustments to their baseline. So you'll see here There's an initiative, excuse me, to establish one consumer credit examiner position in the first year of the biennium, and an additional consumer credit examiner position in the next year. So you'll see those reflected amounts in the position count and personal services. There's also an additional initiative within the Bureau of Consumer Credit Protection to establish a deputy superintendent position in the second year of the biennium. So you'll see those amounts reflected here as well. And again, really all of the agencies that you're going to be hearing about this afternoon are supported with other special revenue funds, not the general fund. The last thing I wanted to just show you to kind of orient you to something different is in the Bureau of Insurance documents. You'll see within the Bureau of Insurance they do receive some of their money from other special revenue funds. Again, the primary source of their funding is from other special revenue funds, but there is a line within the Bureau of Insurance's budget, Federal Expenditures Fund, which reflects a sort of a baseline amount of $10,000. And that's just recognizing their ability to potentially take in additional federal funding through grant funding. But this is just establishing that sort of baseline allocation within the Bureau of Insurance to receive federal funding. And this has been pretty static at $10,000 over the last few years. They haven't received any federal funding, but this is a sort of a recognition or that they could receive that money and would have an ability to spend it. The one other thing I wanted to, Representative Tepler. I think you might be muted.
I'm sorry, I had that phone call.
No.
So I muted myself. Can you explain the difference between an allocation and appropriation for the committee? Thank you.
Yes, I was just going to go and do that because I think it's appropriate. There is a difference in the terminology and in how the budget reflects what's called an appropriation and an allocation. And an appropriation is an authorization by the legislature for spending money from the general fund, and that's called an appropriation. When the legislature authorizes spending by an agency that is supported by other special revenue funds or federal funds, they call that an allocation. And it's just a way to describe the authorization for the funding. The legislature still has to authorize the agency to spend that money. So an allocation is required as part of the budget, but it just reflects the difference between an appropriation from the general fund as opposed to authorizing the agency or allocating an amount to be spent that they've received from other special revenues, or dedicated revenue is another term that's often used to reflect money that would come in from licensed entities to support the operations of the Bureau of Insurance, for instance. The last thing I just wanted to make you aware of is you may see throughout the document there are some initiatives to reflect increases in funding related to both professional services contract and related stay cap charges, and this acronym stay cap, STA-CAP, you'll see throughout, and that is an amount that recognizes the ability of state government to charge various agencies for centrally provided services like IT or payroll or human resources. So the Department of Administrative and Financial Services essentially charges each agency a certain rate to for the provision of those sort of centrally organized services. And you may see some increases reflected in with regard to some of the programs. The Bureau of Insurance, this one both reflects increases in sort of those charges for centrally provided services by state government, but also recognizes an increase in contracts with outside entities. So I think that's why this amount is so much higher than sort of you might see for other amounts. You also will see, as we talk about, if you look at some of the licensing boards later, a few of them have initiatives to provide funding for cost increases associated with services that's provided to them by the Office of the Attorney General. So you'll see, and again, that's a reflection where in the budget where particular state agencies pay a certain amount to the Department of the Attorney General for the services that they receive. I'm happy to go through any of this more specifically, but each of these initiatives and proposals with regard to each of the areas will be presented to you in testimony this afternoon. So I don't want to really be repetitive, but I'm happy to answer any questions that any of you might have.
Questions from the committee? Representative Matheson.
Thank you very much. Colleen, can you just give me some examples of the TA cap? Like, are those payroll? I missed that, I apologize, but these are, I'm not sure I understand exactly what those are. They're centrally located services.
So these would, right, so I didn't mean to interrupt you, sorry.
No.
So this would be payroll is one example. So the Department of Administrative and Financial Services would provide the specific payroll services for the agencies within the department. So there would be employees within the Department of Administrative and Financial Services that would actually perform those payroll functions to pay those employees within that department. And so what a process has been developed to sort of establish a particular rate for each agency must pay to help support those payroll services. So things like that, or access to the central fleet management of vehicles. If someone needs to drive a state vehicle, if they're a bank examiner, for instance, and they use a state car, they have access to the central fleet and they'll be charged a particular rate for those services. Or information technology services is another example, sort of maintenance of computers, software, hard drives, that type of thing. There's a rate that each agency pays for those services, and they're sort of collectively included in that stay cap charge.
May I just do a quick follow-up?
Yes, go ahead.
So that makes perfect sense to me. And are there also, is this mostly centrally located services, or is this also money that goes to contractors that do these services as well? It's just centrally located?
The state cap charges are just for services that would be provided by agents, by state government for the benefit of all of the state government agencies. You'll see that there are some the Bureau of Insurance is an example. As part of one of their initiatives, they were it would provide an allocation for them to spend more money, if you will, on both to reflect their increases in state cap charges, but reflect additional contracting that they might want to do with outside entities for actuarial services, for instance. That's a big one for the Bureau of Insurance. So you may see, but those are usually broken down separately. So you'll see those amounts. And so some agencies do have authorization or allocation to spend money on outside services, but they're usually very specific, like for related to a function of the agency, like with the Bureau of Insurance, whether it be actuarial services, something that they would not have the benefit of having in-house.
Thank you, Colleen. It looked like Representative Evans had a question, but he disappeared on me. So
Oh, I
hopefully
didn't.
he'll come back
Mhm.
and be able to ask his question. Do any other committee members have questions?
Great.
I find the state budget confusing and different than other budgets because of the separation of baseline and initiatives. And that's, that's probably in some ways, the most important thing to pay attention to you as you look at the budget documents.
Mhm. And the other thing to keep in mind is typically the Appropriations Committee asks the committee to weigh in on the specific initiatives, to sort of vote yes or no to include them. But the committee does have really broad authority and policy oversight to make recommendations to the Appropriations Committee. For instance, if you thought there should be an adjustment to a baseline, if an agency, proposes a baseline budget, but if you thought even though they did not propose any initiatives, if the committee wanted to recommend increased funding or potentially decreased funding for that area, that could be something included in your written response back. Particularly, a good example is the issue of the mental health counseling that Senator Sanborn raised earlier. If they're, with particular regard to that budget, if it looked like they haven't proposed any increased staffing, but some of the backlog might be associated with that, then that could be something that as a policy committee, you could recommend back to appropriations.
Yes, and that's something that we certainly might want to talk to Commissioner Head about, and to find out whether the difficulty is the number of personnel that they have in that area doing the assessment of the licensing. Any other questions? I don't know what happened to Representative Evans, but he hasn't popped back. So I think that we are finished with our legislative meeting this morning. Thank you, Colleen, for all that information. I think it's very helpful to all of us. And I want to point out to everyone that I think we each have our own caucuses to go to at noon. And probably people want to get their lunch and get it ready for a noon caucus.
Yep. And I just will say I sent out a link to our folks for the noon caucus that's in your top of your email box.
So thank you, everyone.
Thank you.
And
We'll
see you at 1. Yeah.
Thanks very much.
Thanks, Colleen.
Hey, Representative Evans. I just wanted to let you know we answered a couple questions and finished up, so you're free until 1 o'clock when you need to join the AFA call.
Good.
Hey, Representative Evans, can you hear me?
I can hear you. We're having power in and outages.
Gotcha.
So I missed the last part.
Colleen answered a couple questions, but then we've broken away. I know there's caucuses happening at noon, and then the AFA joint hearing is at 1, but you don't need to be back on this Zoom until 2. Hello, interested parties and everybody. I just wanted to let you know that the HCIFS committee is still in the joint public hearing with Appropriations and Financial Affairs. We were hoping to have them out by 2, but they are not finished up and still doing some questions with the commissioner. They'll be over as soon as they are done, though.
Okay, disregard, because you saw my chat. I just wasn't sure if you were on or off.
Can anyone hear me?
Okay, I think we've got a critical mass and certainly a quorum. Let's get started with this afternoon's work sessions. We already introduced ourselves on this Zoom channel this morning, I think, so we don't need to do that again. So we'll just dive right in. Colleen, I think we want to start with the anesthesiologist bill, the nurse anesthesia bill.
Okay, so we're going to start with LD 254. Do you want me to just go ahead and start the share the analysis and go from there?
Yep, and I think Representative Connor needs to introduce himself, so go ahead and do that, Representative Connor.
Thank you, Madam Chair. My name is John Connor, and I represent House District 58, which is part of Lewiston.
Great.
Okay, then I'll go ahead with LD 254. I did have a chance, I did email this out to you previously because this was a work session that you had tabled, but I also emailed it again today. But I'll go ahead and share the analysis.
This was when we postponed, right? I don't think we've
is.
actually started it.
Never
yet.
actually
Okay.
talked about it. Yep. No,
Yep.
we never actually got to it. So I think you should all see the analysis on LD 254, but hopefully folks have had a chance to review it. This is a bill that was introduced last session and considered by the 129th legislature, but it was not enacted due to the delay because of the pandemic in the legislature, the 129th legislature coming back into a special session. So the bill has been reintroduced and it does reflect the language that was voted on and supported by all of the members of the committee last session. It makes a number of changes related to health insurance coverage for services provided by certified registered nurse anesthetists or CRNAs. It would require insurance carriers to cover those services that are within a CRNA scope of practice and are covered services under a plan. It would permit carriers to impose a deductible or other cost sharing requirements for a healthcare service provided by a CRNA as long as that cost sharing doesn't exceed the cost sharing that's applied to the same service that would be provided by another healthcare provider that can provide that service within their scope of practice. It also provides that carriers may not prohibit CRNAs from participating in their carrier's provider network or billing the carrier directly solely because the provider is a CRNA, as long as the CRNA provider is willing to meet the same terms and conditions as other participating providers with regard to participation in the carrier's network. And lastly, it would require CRNAs to bill for their services electronically and use standard claim forms that have been developed and approved by the federal government. The language would make the requirements in the bill applicable to policies and contracts that would be issued or renewed on or after January 1 of 2023. So these requirements would be incorporated into health insurance plans for the next plan year. As I mentioned, the bill reflects language that was supported last session by the committee. The other thing I would mention is, as it's drafted, and as I mentioned, it would require coverage and reimbursement for services of a CRNA. provided within their lawful scope of practice. There is a provision in the insurance code that members who have served before are familiar with that does require mandated health benefit proposals like this one, which is a provision that mandates health insurance coverage for specific services, specific diseases, or certain providers in health insurance policies to undergo a review and evaluation by the Bureau of Insurance before being enacted into law. The statute as it's written would require the legislation to be sent to the Bureau for their review if after the hearing, a majority of the committee supports the proposal and requests a review. Typically, if a report is required, the Bureau does use an outside consultant to assist them in completing the work. It generally takes about 8 weeks to prepare a report. Section 3 of this bill does provide an exemption from the proposal having to undergo a review pursuant to Section 2752. That same provision was included in the bill last session. So the committee does have the ability to make a policy decision to forego the review and evaluation by the Bureau of Insurance if you choose to do that. And as I said, the language of the bill proposes that it would be exempt and move forward. With regard to provisions like this one that, if you will, are mandated benefits, the Federal Affordable Care Act beginning in 2014 required that states defray the costs of all mandates that were adopted after December 2011 that are included in health plans unless those mandates were already required as part of the essential benefits package. Federal guidance, however, has indicated that provider mandates, so coverage of provider services like as in LD 254, are not considered additions to the essential benefits package. So the state in this instance would not be responsible for defraying the costs of any additional benefits if this bill were enacted. However, there may be some potential additional premium costs for private plans. You also should consider any additional costs to the state employee health plan, because although the state employee health plan is self-insured, specific state law requires that they comply with all mandates that health insurance carriers are required to comply with in Title 24A. The language that is reflected in LD 254 and went through review last session did indicate that it had no fiscal impact. So although this bill has not gone through a review, since it is the same language as last session's legislation, I would anticipate a similar fiscal outcome for the fiscal review of this bill. Lastly, I just wanted to note that the current law does have provisions that sort of define what the scope of practice is for CRNAs, and they are permitted to practice independently without supervision of a surgeon or other physician when providing services in critical access hospitals. As I read it, what LD 254 would do would require coverage and reimbursement for CRNAs who are practicing and providing services that are within their scope of practice. I don't believe the bill as drafted expands their scope of practice in any way. It specifies that carriers will cover the services that are within their scope of practice and if those services are covered under a health plan. And then lastly, just for your information, there are provisions in current law that do require health insurance carriers to provide coverage for other types of advanced practice nurses, like certified nurse practitioners, and certified within their lawful scope of practice. And I noted and just included for you the statutory references to those sections in current law. And I mentioned the fiscal information. So I think I'm done and I'm happy to answer any questions that you might have. I guess I'll stop sharing too, so everyone can have their discussion.
Thanks, Colleen. You mentioned the effective date is January 1, 2023.
Oh,
And
I think that's a mistake. Yeah, it is. Yeah, that's a typo.
Okay.
It's intended
so
to be
it's
the next
2022.
2022. Yep, that's
Okay,
my
good.
mistake.
Perfect. Then I have no other questions. Does anyone else on the committee have any other questions? All right. Seeing none, are we ready for a motion? Representative Morris, go ahead.
Yes, I will make a motion ought to pass.
Great. And Representative Tepler seconded the motion. Is there any further discussion? All right, seeing none, the clerk will call the roll.
I do want to clarify
Oh,
one
Colleen.
thing if I could. I'm sorry. I was trying to raise my hand, but I don't think you can see it because
No.
it blends
Oh,
in with
'cause
my
it's the same
background.
color as your pink
I-
background.
I know
Yep.
it blends in with the background, so I apologize for interrupting. I did clarify the language of the bill as written does say 2023. So if the committee is, and that's the way it's drafted. So if the committee is interested in having it be incorporated into the next plan year, which will be 2022, I would recommend just making an amendment to change that.
Representative Morris, will you take that as a friendly amendment?
Yes.
Okay. Great. So the motion is ought to pass as amended with the effective date of 2022. And the clerk will call the roll.
Okay, Representative Quint.
Yes.
Representative Quint ought to pass as amended. Representative Connor.
Yes.
Representative Connor ought to pass as amended. Representative Blyer.
Yes.
Representative Blyer ought to pass as amended. Representative Morris.
Yes.
Representative Morris ought to pass as amended. Representative Matheson.
Yes.
Representative Matheson ought to pass as amended. Representative Evans.
Yes.
Representative Evans ought to pass as amended. Representative Arford.
Yes.
Representative Arford ought to pass as amended. Representative Millerano.
Yes.
Representative Millerano ought to pass as amended. Representative Brooks.
Yes.
Representative Brooks ought to pass as amended. Senator Stewart.
Yes.
Senator Stewart ought to pass as amended. Senator Brenner.
Yes.
Senator Brenner ought to pass as amended. Representative Tepler.
Yes.
Representative Tepler ought to pass as amended. Senator Sanborn.
Yes.
Senator Sanborn ought to pass as amended.
Okay, great. So we're going to give Colleen a second to catch up. And Colleen, if we could take up LD 274 next, that would be great. So we'll open a work session on LD 274.
Okay, great. I'm just going to close this one and pull up LD 274, which I think everybody should be able to see. Now, this is LD 274. This was resolved, sponsored by Representative Tepler, which would direct the MHDO to determine best methods and definitions to use in collecting data to assist in analyzing the origins of racial and ethnic disparities in healthcare in the state. The bill as it's drafted would require MHDO to submit a report based on its evaluation, including any suggested legislation that may be necessary by October 1 of 2021 to the HCIFS committee. And then the bill as drafted would authorize the committee to report out legislation to the second regular session of the 130th legislature. The testimony from MHDO did indicate that their data users group has stressed the importance of collecting and releasing data specific to race and ethnicity, and also that the federal CDC data code guidelines are in place for race and ethnicity. And more recently, interest among the users group has broadened to include the collection of data related to social determinants of health to help better understand health outcomes and disparities based on race and ethnicity. Their testimony indicated that if the resolve moves forward, they would complete an environmental scan to help identify best practices for defining, collecting, and integrating this data into their the data sets that they require providers and others to report to MHDO. There was testimony from several interested parties noted that data is needed to measure racial and ethnic disparities to help inform policy making in this area. I think that's the intent for why the bill would help identify current gaps in data collection and provide the potential for the bill to lead to improved data collection and analysis. It was also just suggested that the committee might add language specifying that MHDO consult with certain stakeholders, like the Maine CDC and the Maine Public Health Association. As drafted, the bill would give MHDO discretion as to how to conduct the evaluation and who to consult with. So I leave that to the committee as to whether you think the additional language would be necessary. The last thing I would note with regard to this bill here is related to the timing. The bill would require MHDO to submit a report to the HCIFS committee by October 1 of 2021. Typically, bills that are enacted in the first regular session become effective 90 days following adjournment, sine die. That usually is sometime in September of the calendar year. So you may consider the timing and think about that. You have a couple of options. You could consider adding an emergency preamble. So the resolve would become effective upon the governor's signature, so that by statute, MHGO would be required to perform the duties required in the resolve. Alternatively, you might consider extending the report back date for MHDO with the understanding that the resolve would authorize submission to the next session starting in January of 2022. So you could think about, instead of a report date of October 2021, you could push it back to January or February, and it would still provide an opportunity for legislation to be considered in the second regular session. I'll stop there.
Thank you, Colleen. I'll open it up for comments or questions from the committee. Representative Quint, you unmuted yourself. Did you want to speak?
Yes, sorry, I did them in the wrong order.
That's fine. Go ahead.
Thank you, Madam Chair. I actually have some problems with some of the critical race theory bills coming forward. However, this bill, I believe, has merit, just from being in the House bill myself. And I think if you look at disparity, you can say just race, but I think you would see disparity in rural areas of Maine as well. So I don't think it's just a racial issue, but I think that that aspect of it does need to be studied. And so I'm just wondering if adding in the cultural aspect. So ethnic, the racial, ethnic, and cultural. You have the ways that families are living together can play into their health care. The number of people living in an area together can also play into that. And I know just with medical missions overseas, the color of skin, not everyone with black skin has the same exact things going on. There is difference that's added in. And so I'm just wondering if anyone else has thoughts on that, if that's something that you would entertain. And I'm actually glad that this is being looked at in the healthcare field.
Representative Tepler, did you want to address Representative Quint's question? Go ahead.
Thank you very much, Madam Chair, and thank you for the question, Representative Quint. I think what I would say is that what we're asking the MHDO to do is to identify some of those issues that you were just talking about as determinants based on race and ethnicity. And we didn't include what I think you're referring to, which is, less cultural issues than economic issues or geographic issues. But I think that our all claims, all payer database already encompasses a lot of those issues. The problem is that we don't have racial or ethnic identifications in our data. And the MHDO isn't just looking for skin color as an identifier, that it's much more complicated than that, and really involves the way that the federal government and other states are looking at race, which is a social construct, and to understand how that socially constructed category works in conjunction with the healthcare system to create the disparities that we saw in communities of color during the pandemic. Does that make sense to you?
It does make sense. However, it doesn't. When it says just race or ethnicity, the amount of melanin in your skin shouldn't just be the deciding factor, like you were saying, looking at someone. I really would like to see the wording of cultural in there too, because if you look at society, Chicago, Illinois is different from Portland, Maine. So I don't think that you could take those two and say, well, the color of the skin here and the color of the skin here is why this is occurring. I really feel that it's not, when you leave out the cultural aspect, you're going to miss vital information that I feel is to be able to actually make recommendations and to see how to best serve the communities going forward.
Okay, so Representative Tepler, with your forbearance, I just want to see if I can reframe the issue a little bit. Because with regard to things like Chicago versus Portland versus, Holton, we have really great granular data by zip code on health outcomes, on health access, on health coverage, on health cost, all of those things. So MHDO already has really great granular zip code information. What I think this bill is meant to address, which I really appreciated that you were supportive of in what you described at the beginning of your comment, is that we don't have any information about it, to be clear, not about the color of someone's skin, but about the way they racially identify themselves, right? So race is always something that is self-identified and is collected in some way based on someone's indication of what race they are. And ethnicity is the same. So it's not just melanin. It's not like somebody, we're going to have some piece of data about how dark skinned someone is in their medical record or in our medical MHDO database. It is in fact about how people identify themselves within these social constructs of race and ethnicity. So I worry about the word cultural because I'm not sure I know what it means beyond what I just described. So I don't think of myself as being like culturally from Cumberland County, but my zip code would tell you that that's where I live. But that doesn't strike me as capturing what you have in mind as cultural. So I wanted to see if you had another, if with that reflection back, you wanted to give us more of a sense of what you're looking for in the word cultural, because I don't want to give MHDO a task that's never been asked in any other state. That word cultural, they won't know what it means, and then I'm not sure what they do with it. So maybe you can say a little bit more if it's still something that you want to add.
Yes. When we look at the different community groups, you have cultural differences and religious differences going in. And I think a lot of our ethnicity groups in Maine, we do have those standards. I think of when, I work in Haiti or Jamaica. Two completely different cultures. They come about things in different ways, and to try to just lump them together in one people group, I'm really concerned that this can happen, that it would go on racial and ethnic boundaries, but not really bringing in the cultural ties that do come with that. The same thing if you have people coming from Africa, whether they're from Sudan or Ghana, there's two different, their outlooks are different. And that's where my concern is. Those outlooks will be looked at in that. And I think it's really important in the medical field, because as a nurse, that's one of the things that we're supposed to pay attention to. We're supposed to pay attention to the cultural differences and the people that we're working with. And I just don't want that to be overlooked and have this. I really feel that these bills have a tendency that they'll go into the racial ethnic issue, and then they're going to miss out really what can help the community a little more focalized. So I'm not, yes, please, Ms.
Representative Tepler, go ahead.
Thank you, Madam Chair. And I guess Representative Quinn, I understand what you're saying. You don't want really blanket groupings created like black, white. You don't want those. And I think that the reason that I put this in the hands of the MHDO was because I believe we're developing more complex kinds of descriptions of people's racial identities than that in our data streams now. So yes, African immigrants certainly don't consider themselves to be African Americans. They consider themselves to be Africans who are living in America or who may become Americans. So I fully understand that, but I think that's why I wanted to put this in the hands of the MHDO, because they understand the complex nature of the way that we collect data and the way that we analyze data. And I don't know what the sort of more generalized data streams are out there now that help them to sort through those differences, and what the definitions and methodologies are that help them to sort through those differences. But I believe that Karen Lee Harrington knows, or if she doesn't know, she knows who to ask.
Sure. I mean, I think what I heard Representative Quint was sort of a question about the granularity of ethnicity, right? So someone who's Ghanaian may think of themselves as Ghanaian, or may think of themselves as, you know, from a particular region in Africa, or so forth. And at some level, right, we have to draw some lines in order to be able to collect data. And it's up to the MHDO to determine how granular we make the ethnicity determinations within this particular data set, because at some point they become so granular that they're not useful, though they would be useful potentially for patient care, right? Because patient care is different, right? Like individual, the patient in front of you, you're going to deal with the patient in front of you. But when you're looking for trends and when you're looking for things on that sort of use of big data kind of concepts to spot trends and deal with trends and improve care, that's where we have to figure out what level of granularity is appropriate.
Madam Chair, can I also say something else? The bill allows us to have another cut at this. So the bill asks the MHDO to come back to us with those definitions and methodologies. And at that point, if we don't feel, Representative Quint, that those definitions are adequate, that we feel that they don't have the granularity, the moving down the scale of complexity, or moving up, I guess you would say, the scale of complexity that we feel is needed, we'll have an opportunity to say so. And we can report out a bill that requires them to go back to the drawing board. We could, or we can get a bill at that point that moves this forward by requiring providers to provide us with more complex information.
Representative Quint, go ahead.
Okay, so then if I can just ask then on a personal level, if it came back and it did not have those sorts of guidelines, is this something that the committee would be in favor of addressing? I hate to see it slip by and then not have it come up again, because I understand what you're saying with just patient care, but the thing is, if we don't have this information, we can't give the overarching foundation that's needed to provide this medical care. If we're doing each individual basis, we don't have the guidelines to go by in dealing with the community as a whole. And I think that's important, especially because we do have, you know, a larger, I'll take the Somalians, for example, a larger population in that community. I think it's important that we do have that information.
Yeah, I think that's right, Representative Quint. I think it's a question of what the data is going to be used for, and how it's used, and what it can spot for us. So I think it's a question about training, training and provision of patient care is a little bit different than the questions of access and equity, but they're related for sure. So I understand what you're driving at, for sure. But I think it is captured within the word ethnicity, depending on how granular, and granularity is always a balancing act, right? Because the more granular you make something, the less useful the data is, because it gets really noisy. And then it becomes difficult to spot trends or group large enough groups of people together so that you can actually make useful population level data. But that's the balancing act that the data scientists should figure out for us, rather than us, in my view. Senator Brenner, go ahead.
Thank you, Madam Chair. I will just I'm in support of this bill, and I'm looking forward to the outcome of having the data to look at for policy work, but also for practice work as a nurse midwife and a nurse. I do think that there are many examples nationally of organizations that have done work around racial disparities in healthcare, that have language and models that that we will be able to use to look at to create the model that we want to use for the data that we think is important to collect. And we might find that we collect more data than we need and we can pull back, or we might find that we aren't collecting enough and we need to tweak it. But it's never a done deal. It just means that we're saying this is valuable, important, it's meaningful. We believe in having this information so we can make good policy with regard to all Mainers. And I think we should move forward with it.
Are there other comments from the committee? Representative Morris, go ahead.
Yes, thank you, Madam Chair. Well, I was on the governor's economic recovery committee, so we discussed a lot of this as it was going on in real time, and I'm just trying to kind of I think both Representative Quint and Representative Tepler are after the same exact thing. We're just trying to figure out the best way to define it in this bill. And I know we had a presentation on this, and I don't want to misquote it. At one point during one of those Friday meetings around, I think what Representative Quint is trying to get at around, you know, it's not just about the ethnicity and the race. When she's talking about the cultural, it's also, I think she's trying to figure out sort of what folks may do for a living. So if they're working on front lines and things of that nature, as well as what their home life situation might be like as well. I think that's kind of what Representative Quint is driving at. And I think Representative Tepler's is, and I don't want to, if I'm misstating your position at all, please let me know, or I see you have your hand up, so maybe I'll let you.
She'll let you know.
Yes, thank you.
All right.
May I, Madam Chair?
Go ahead, Representative Tepler.
Thank you, Representative Morris. The only thing I want to say is that when Ms. Harrington was present with us, she indicated that one of the issues that they're looking at is the social determinants of health. And that is exactly what you're talking about, Representative Morris, the social determinants of health. And those are issues like poverty, which isn't a racial or an ethnic issue. Those are issues like your living situation. So the social determinants of health are part of her plan in creating a methodology for examining where these disparities come from, because we know they don't actually come from the color of people's skin. So the question is, where do they come from? And I think that the issue of the social determinants of health, if you look back at her testimony, you'll see that that's part of what she talks about.
Representative Evans.
Okay, all of you are correct. I know exactly what Representative Quint is talking about. We've done a lot of this at the American Medical Association on social determinants of health disparities. And it's not just the skin color, it's all of the other factors that have been mentioned. It can be because of different generations, multi-generations in one home, job, education. So all of these factors together are important to look at. And so I certainly understand what she's saying, and I see where the, Representative Tepler is leading in her proposal, is to get something started. But once you get it started, you want to, a lot of these other things are probably going to be more evident. And we will realize that we need to include those as well. So we have a lot of information already on that as a source for whoever may take this up at the American Medical Association.
Right. That would be part of the environmental scan that the bill contemplates, I think. Are there additional comments? Representative Arford, go ahead.
I just would like to add this to the conversation that the Maine Health Data Organization, as Karen, the director, explained to us earlier today, collects data from a number of different sources, but the primary source is the All Payer Claims Database, which means that every single health insurance claim that is paid in the state of Maine is reported to them. It's an incredibly rich, informative data source. And what's really important to know is that Maine is one of only a few states that collects this data for a number of reasons, which I won't get into now, but we have the data to work with. And that's what really informs this legislation, that we have it to work with. We have an agency that can produce this report for us. And my suggestion is we go ahead and vote ought to pass unanimously, see what comes out of it. And then if we want to add more to this in the future or subtract from it, we can. But to pass up on the opportunity to do this work now, honestly, as we're passing up on something that the people of our state, I truly believe, would want us to do.
Thanks, Representative Arford. Are there additional comments? All right. I would love to see us get to a unanimous report on this bill because I think it's really, really important. And I actually think, as Representative Evans pointed out, we agree with each other. And whenever we agree with each other, I would like us to try and reflect that back to the rest of the legislature and not create unnecessary divided reports. So what I'm going to suggest is that we table this, and we're going to bring it back on Thursday. You know, that's my suggestion. And before I make a motion or take a motion on that topic, I'd be happy to hear other comments before we close this work session. Representative Tepler, go ahead.
Thank you, Madam Chair. What I'd like to suggest is that Ms. Harrington be present for our next work session, that we ask her if she can join us so she can explain her approach that this bill will sort of kick off. And what the report to us will look like when she finishes it. Because I think both of those things would be helpful for us to recognize the level of agreement that we have.
Yep. Representative Morris.
Sure, unmute here. Yes, I would agree with what Representative Tepler said. I think that I think we just need to probably discuss it among our group a little more. We can get a better understanding of what's where it is we want to go with this, and certainly we can discuss it more on Thursday.
Okay, thanks, Representative Morris. At this point, seeing no other hands raised, I'll entertain a motion to table. Representative Morris, thank you. Second. Is there a second? Representative Quint seconds. All those in favor? Okay, it's unanimous of those present to table LD 274 with the intention of bringing it back on Thursday for final discussion. Okay, great. So with that, whoops, I didn't mean to hit mute. I was going to lower your hand, Representative Morris. Okay. Great. So next we're going to pick up LD1, and Colleen, I think the way that I'd like to work with LD1 is just to take it as if it's separate bills almost, so that we can discuss each separate section and then move on to the next section. So let's start with section A, or part A of LD1.
Start with A? Okay.
Yeah,
I
I think
did-
that's fine. It's not the
Okay.
easiest section, but we'll start there anyway.
No, I know. I did organize the analysis that way and tried to separate out the issues. But I think everybody can see this now. So I did want to note that this does reflect the sponsor's amendment to LD1, and there have been the sponsor also suggested 2 additional technical changes to Part D that I'll note when we get to the discussion about Part D. So the amendment that was presented prior to the public hearing and we asked folks to comment on was intended to replace all of the language in the original bill. And so I did try to lay out in the on the slides here the issues that were raised with regard to each particular section of the proposal. And there's 4 parts. So there's part A, B, C, and D. And just quickly in Part A, those are the provisions that require health insurance carriers to provide certain coverage for COVID-19 screening, testing, and immunization services. Also would prohibit carriers from imposing cost sharing requirements on consumers for those services. So it's important to keep in mind that these provisions apply to health insurance carriers, so would not apply to other types of people covered under other types of programs like main care, Medicare, or covered under self-insured plans. There is also a provision in Part A that directs healthcare providers to provide certain notices before providing screening or testing for COVID-19, particularly with regard to any costs that would be associated with providing those services. Do you want me to just briefly summarize all of them and then go to A, or do you want to just go straight into the issues?
No, I'd like to go straight to A.
Yeah, okay. So as I mentioned with Part A, these next few slides sort of lay out some of the issues. As we talked about with the prior bill, LD 254, Part A does require health insurance carriers to provide coverage for screening, testing, and immunization for COVID-19 as sort of a standard benefit in all of their policies. And as I mentioned in our prior discussion, there is a provision in statute that requires these types of proposals to undergo a review and evaluation by the Bureau of Insurance before they're enacted into law. As I mentioned, also, the committee does have authority to exempt the proposal from the mandate review. If the committee decides to move forward with these provisions and would propose exempting them from the review required in statute, there should be additional language added to the amendment. Unlike LD 254, that was not included in the proposed sponsors amendment. So I would recommend that. And then we also talked about the responsibility of states to defray the costs of any mandates that have been adopted since December 2011. With regard to the provisions in LD1, the ACA does require coverage for certain preventive services that are as part of the essential benefit package. And Title 24A was amended in the previous legislature to codify that ACA requirement in state law. So preventive services are required to be covered as part of Maine's essential health benefits package, and it would include certain recommended immunizations and services. If COVID-19 screening, testing, and immunization were recommended as preventive services under that provision in current law, then they would become part of our essential health benefit package and may not be subject to defrayal. And you did hear a number of folks who testified recommending that maybe these provisions may not be necessary since there's an expectation that they might be included or will be included as preventive services, and so would be covered under that existing provision of state law. You might want to consider, though, that there may be some additional costs to the state employee health plan for these provisions. As I mentioned, the state employee plan is required to comply with any mandated benefits in Title 24A, so they would be required to add these benefits, even though they are a self-insured plan, because it's the state employee plan. We have authority to make decisions about what benefits they provide. There have been emergency response orders issued by the superintendent of insurance during the pandemic that requires health insurance carriers to cover medically necessary COVID-19 screening and testing with no cost sharing or prior authorization requirements. Part A, as it's drafted, would require coverage by insurers for screening and testing more broadly. It does provide an exception for surveillance testing. Carrier representatives in their testimony suggested that the committee consider further limiting the scope of testing, thinking about possibly requiring only medically necessary testing after the declared pandemic is over, thinking more about sort of routine employer testing that might be required and not considered surveillance testing, also thinking about what they termed sort of lifestyle testing for folks who may be traveling. And as drafted, Part A would make these requirements sort of permanent on an ongoing basis in terms of their requirements for coverage. Part A also would require coverage for COVID-19 vaccinations and associated costs of administration of vaccines, including facility fees. The current insurance emergency order does require carriers to cover administrative fees, does not specify that they pay facility fees. And you did have some concerns raised by representative health carriers about this additional language in the amendment. They also raised some concerns related to references in the language as drafted to requiring coverage for processing fees and clinical evaluations associated with immunizations. The bill also, the proposal specifies that any bill that someone receives from an out-of-network provider for COVID-19 screening or testing must be treated like a bill for out-of-network emergency services. And so that would trigger some of the provisions we've talked about with previous legislation in terms of setting the reimbursement rates for those services and also allowing disputed bills to be part of the independent dispute resolution process that would be available. So they're treated, if you will, like a surprise medical bill, or particularly here, out-of-network emergency services are treated under that section. The bill, as it's drafted, only applies this treatment to out-of-network provider bills for screening and testing for COVID, and not to any bills that they might receive for COVID-19 immunization. So I wanted to note that difference in the way the bill is drafted for you. The testimony from the Bureau of Insurance also noted that there are provisions in current law that prohibit balance billing for out-of-network provider bills for covered emergency services. And as I mentioned, LB1, as it's proposed, would treat an out-of-network provider bill for COVID-19 screening and testing like those bills. So the committee may want to specify that providers may not balance bill for those services. And if you do, I would recommend adding specific language to that provision in Title 22 to make sure that these types of bills are treated like covered bills for covered emergency services or other surprise bills. Additionally, as I mentioned, there's a provision that requires providers to provide certain notices to patients prior to COVID-19 screening, and representatives of providers in the testimony from the Maine Hospital Association, Maine Health, and Northern Light Health, they suggested some amendments to the wording surrounding these notices, and also to the language that would prohibit providers from charging uninsured patients, and they suggested making some specific changes to the wording. I can go through that more specifically for you if you wanted to look at the language of the amendment as we move forward. And then I guess the last issue that was raised, particularly with regard to Part A, that I wanted to mention is the provisions as drafted, as I mentioned, would make these changes permanent. So there was some suggestions that the committee consider applying them only during the current pandemic, or perhaps considering a sunset date or a repeal date in the future, so that the legislature would have to come back and take a look and make an affirmative decision to continue them moving forward. I think that was it for Part A.
Thanks, Colleen. Okay, so I think that gives us more than enough to talk about in the first instance. And I need to, sorry, I'm going to pull them back up. Yeah, if you don't mind, I think I can. Yeah, I think I can still manage the conversation okay, if I have the panelist panel open. So yeah, if you would pull it back up, that would be great. And I can see the raised hands. Just keep in mind, guys, that I can't see your physical hands while we're screen sharing, but if you use your raised hand, I'll be able to see you. But I think it makes sense because there are so many issues to take them paragraph by paragraph within Colleen's analysis, because otherwise I think we're going to lose track. And so the first, I guess the first two issues really are about mandate review. And I'd kind of like to even separate them out further, which is mandate review for screening and testing is one question, and then mandate review for immunization is a second issue. So just because I think this is complicated and I want to be helpful, I'm going to suggest that mandate review for immunization is not much of an issue because that's clearly a preventative service and would, I think, clearly become part of our preventative services provision of our EHB. Does that sound right to you, Colleen?
Yeah, I think so. I think the vaccines are probably more likely to be considered as a preventive service. Other vaccines like the flu vaccine and other things are already included as part of preventive services.
Okay, so that seems fairly straightforward to me, that mandate is not going to cause an issue. With regard to screening and testing, we heard a lot of pushback from insurers with regard to medical necessity, but I can't tell you the number of constituents that reached out to me about having their COVID test coverage denied, and then calling, and then it was immediately covered. As soon as they sort of put their hand up and said, no, really cover it, it was covered. But a lot of people don't know to call. And as a result, it struck me that an awful lot of denials were just going out because they could, because of this medical necessity question. So I'm curious what the rest of the committee's thoughts are on this issue of screening and testing being, the default rule being to test and to cover it. Representative Morris.
Yes, thank you, Madam Chair. I actually had a call last week from a constituent as well that his mother lives in an assisted living facility, has some dementia, and they sent him a bill for the testing, even though it was supposed to be covered. And then there was all kinds of other issues with it going to a collection agency. So I've heard those concerns as well. I think the issue with this right now is today I would say yes, without going forward, without necessarily having to do a mandate review. I think the concern I have is right now we're still kind of in the fog of being in the middle of this pandemic. And so in a year from now, how are we going to feel on that issue? And so I think that's kind of the push and pull factor for me. I think today, absolutely, because it's important to get us back to health so life can get back to normal as soon as possible. And obviously that includes having these tests covered right now. The question for me is, as life returns to normal, how much are we going to require, particularly when we talk about those situations where someone decides to take a trip and then return to work? It's, do we want to make that, at least once the state of emergency is lifted, continue to require businesses and insurers to cover that? I think that's really the question in my mind, and where the push and pull factors are within my own mind.
Thanks, Representative Morris. Representative Evans.
Yeah, I understand what Representative Morris is talking about. Yeah, the other aspect of it is I think it should be required because one, if a person is going to undergo a procedure, this is a test that you would want to have before you went forward with that procedure. The other aspect of it is we don't know how long this is going to last, especially with variants. Until this could this could take a couple of years. We could always come back and change it. But for now, I think it should be it should be included.
Thanks, Representative Evans. Representative Tepler.
Thank you, Madam Chair. And I have to agree with Representative Evans. And I guess what I would say to Representative Morris is, if it's not a big problem, if a year from now we have the pandemic under control, this just isn't going to cost insurance companies a whole lot of money, because there won't be a lot of testing. And this already lets out the kind of testing that colleges might be doing, or other organizations that test a whole big group of people, the surveillance testing. But, you know, I really do think that it's a public health preventative service. If we don't test people, we won't know that they're sick, and we can't make sure that they get better. So to me, the testing is important, and if things are still bad enough that this costs the insurers a lot of money, well, then we really need it.
Yeah. Representative Matheson.
Thanks so much. I think this is a really interesting conversation, and it's really important to remember that screening equals oftentimes prevention, and cost associated to people who get sick is significantly greater than screening to see whether or not they are sick or they can transfer that. And being in integrative medicine, I feel so strongly that prevention is so much of a better way of reacting to healthcare rather than reacting to sick care. So I really strongly support the screening to prevent illnesses from happening, because putting somebody on a respirator is way more expensive than getting a COVID test. So that's just one point of view that I would add to this conversation.
Thanks, Representative Matheson. So I guess just to chime in, I think, you know, my response, as I've been thinking about the sunset question, is that, like Representative Evans, I am very concerned that we don't know where the end of this is still. I have great hope that the end of it is around Memorial Day and we all get to reopen our businesses, like my business, and go back to our pretty normal lives pretty quickly. But I'm not at all certain that we aren't going to have another enormous surge, for example, in the winter next year, in the fall. We don't know yet. And we don't know how long the vaccine is effective for. We won't know for a number of years. So I would rather treat this as something we need to come back and repeal, or as Representative Tepler noted, it simply fades away in terms of its level of importance, because if we do have people traveling and then they want to get tested upon return from travel because they're traveling somewhere, for example, that's still struggling to vaccinate their population, we really want them to get tested. And not just this year, but like next year or the year after. We really want them to get tested, like maybe even more than right now, because that is going to be the testing that can help us prevent a future community spread situation. So I've really thought a lot about whether to put in a sunset here, and have really decided that that we shouldn't. And you know, would love to hear from other members on the committee if they disagree with that. Representative Morris.
Yes, thank you, Madam Chair. Well, 2 points. As I understand it, if someone needs a procedure, like my father had to have a hip replaced earlier this year, so he had to have the COVID test. And as I understand it, that would still be required even under the current law. And I think what is, I was just reading through some testimonies, and Chris Austinfort submitted testimony that apparently that Friday there was a question about, may plans and insurers distinguish to the Center for Medicaid and Medicare Studies between COVID-19 testing of asymptomatic people that must be covered and testing for general workplace health and safety for public health surveillance or other purposes not primarily intended for individualized diagnosis or treatment of COVID-19. And about halfway through the answer, it says plans and insurers are not required to provide coverage of testing such as for public health surveillance, which is out of this bill, or employment's purposes. And I think, again, it's something where I think if someone decides to take a trip during this, knowing what the risks are, and they come back and want, and their business requires them to have a test in order to return to work because they don't want to infect other people, I would prefer to leave that at the discretion of the business itself as to who pays for that, as opposed to putting it in law that says the insurer or the business that's paying for that insurance would have to cover it. Is just my personal thought process on that, because again, it's your decision if you wish to travel right now. And there are still certainly travel advisories. So what I would just, what I'm only suggesting is that for those instances where your employer requires you to have a negative test to return to work, I have a little bit of heartburn requiring that to be paid for by everybody who's on that insurance, so the entire employment pool, as opposed to having the individual have to at least pay something for that test, whether it be the copay or whatever. Because that will get expensive for what is essentially a lifestyle testing.
Representative Morris, as a business owner, I would just want to try and give you like a specific example of how this has played out for my employees. So what has happened in the past for one of my employees is that she was exposed outside of work, or she thought she might have been by a friend. And she went to a provider. They asked her if the reason she was there is because she needed a test in order to return to work. And she said yes, because it was true.
Yeah, no, that's fine.
And therefore she got a full bill, but a denial from our insurance. But the real reason she was there is because she had been exposed to COVID potentially. Right. And the insurer absolutely had an obligation to pay that. And so if she had known to say, no, I'm here because I was exposed to COVID, then she would have had it covered. And that's the problem, really, is that we don't have sophisticated individuals who know exactly how to say the right magic words, because both things are true. So she didn't know. This is a 20-something young woman. She doesn't know that it matters whether, she had come to me for advice. Where do I go to get tested? So in fact, she had been sent to the provider by her employer, but not because of pre-employment testing or return to work testing, but that was enough to get her a denial. Yeah. And then she didn't know to tell me about it for months. So this is the problem we're trying to solve. And because we're in the middle of a pandemic, there's a policy reason we have to solve it right now. And it might cost a little bit more to our insurers, but frankly, they made record profits this year. And so I'd kind of like them to pay a little bit more for COVID testing so that we can get out of this. So that's my 2 cents. I'm a little passionate about this, as you can see. Representative Brooks, you haven't joined in the conversation yet, so I'm going to call on you next, and then I'll come back to Representative Tepler.
Yes, I definitely think that where we're in the midst of a public health crisis, if there's a barrier for people getting tested, whether that's a barrier of, if that's a barrier that's money, and that's a financial reason they can't afford the testing, that really presents a huge challenge to everyone. This is a very transmissible virus. And if somebody doesn't get tested because they can't afford it, that really adds to the crisis that we're experiencing. And also, if a person needs to have clearance to go back to work, a lot of times that does go back on the patient and their insurer to get medical treatment if they have insurance.
Thanks, Representative Brooks. Representative Tepler.
Thank you, Madam Chair. And I just want to point out that there are people who are still having to travel for work.
Yes.
And that their work actually sends them places. And I don't know how in policy we would distinguish between vacations and voluntary travel and required work travel. Because certainly if someone's required to travel for work, I would really hope that their insurance is going to cover their testing on either end of that trip.
Yeah. Representative Morris, go ahead.
No, absolutely. I agree with that. If you're required to travel for work, that is different. And I guess it's almost, I guess what I'm kind of after, or what I'm kind of trying to say, is that if you have, and I understand your predicament, what you're discussing, Senator Sanborn, and your unique situation, but I guess it's more a, if that person, you know, if something from their job that would indicate to the insurance company that the whether the travel was job related, or you know, it was just they decided to take a vacation during this time. I think that's really what I'm after. And again, I certainly understand the importance of people taking vacations and the need for mental rest and relaxation. But I think what I'm just saying that I would want us to think about is that question of, you know, you need it to return to work, and in that situation where you were exposed, because that's another valid argument, concern, Senator Sanborn, is someone who is out, you know, like I could go to the grocery store tonight and be exposed to it and have to get tested. And so I understand, or go to a restaurant, and we don't want people to, you know, people still have to be able to go about their lives, and we want them to be able to return to work. So I understand what you're saying, but I think it's more in those instances where you're going somewhere where you know there's a chance for exposure. They need you to, it was your choice to go, in other words, and versus
Representative Morris, I think we see where you're coming from. I guess I just worry about whether it's the insurer's decision or whether it's the patient's decision. And you know, and that's the problem, is when the insurer starts going in there, you get a lot of denial. I apologize for
don't want
interrupting.
people getting denied if the employer says we need you to get this test, from the standpoint of, because in your instance the individual did nothing wrong, they just were exposed through their everyday life. Or Representative Tepler's instance of someone that because my brother has a job where he's required to travel for work, absolutely, then you know the insurance company should pay in that instance. It's when that travel, the situation of I decide to go on a trip somewhere for leisure, I think that's what I'm just saying is, should those instances be covered? And I have concerns because of, especially in the next year or so, people are getting a cabin fever worse than usual in Maine, and may travel.
Let me get Senator Brenner involved as well here. Senator Brenner, go ahead.
Thank you, Madam Chair. What a fantastic discussion. From my point of view, I feel like making sure that we offer a vehicle for covering the cost of testing is crucial to opening the economy. It is not our place as policy makers to pass judgment on the activities of the citizens of Maine with regard to where they may have been exposed to COVID. But if we want to open the economy fully, we need a robust testing program, and that includes a vehicle for covering the cost. And that's what this does. And, you know, all the conversation around if we have to go in and change it at some point when COVID lingers for too long or it goes away. What we need is a vehicle for covering the cost so that people get tested and they're not afraid of the expense. And it's just not our position, I don't think, our place to make judgment about where they're exposed and why they need to get the test. We just need them to get in and get the test so that they can make judgments about whether or not they need to stay home or whether they can keep going out and being a part of our robust economy.
Representative Tepler, go ahead.
Thank you, Madam Chair. And I just want to say that I think I understand the Representative Morris's desire to get some personal responsibility in the mix. I think that's what he's driving at, and I understand that. I think, though, there are times when distinguishing who should take personal responsibility in a certain situation from others who may not have to take personal responsibility for the situation they find themselves in becomes more difficult than actually just blanket covering people. I mean, we get a lot of free riders, but that's typical in healthcare. There are free riders, and that's too bad. But you know, the provision of healthcare is, as you know, Representative Morris, of market failure. It doesn't set price at the same place that demand and supply come together. So, you know, free ridership is just part of that market failure.
Yeah, Representative Evans.
Thank you, Madam Chair. I just want to, I feel pretty strong about this. And I just want to go back to what Representative Matheson said in her comments about prevention. I have a deep concern that things are not going to be as short term as we think they are. There are already cases documented are now getting the virus again. Testing should not be left up to insurance companies, especially under these circumstances. Insurance companies, and I deal with them, I'm in private, they are programmed to deny any kind of a claim 60%, because they know that 60% of the time people are going to accept that denial. So this is a situation where it's not just an individual that we're concerned about. We're concerned about the public health of the nation. And this is a situation where sometimes you have to draw the line in the sand. And this is where I draw the line in the sand. I don't like insurance companies making medical decisions, especially of this magnitude, that potentially my brother had COVID. So I am very, you know, if I have a patient that I take out, I do a colon, a bowel resection on, and this patient may have other comorbidities. The patient may end up on a ventilator. I want to get that patient off of that ventilator within 3 days. If I don't get that patient off the ventilator in 3 days, they may never come off. They become dependent on it. And we talk about cost, the cost just drove up. And if this patient ended up having COVID and wasn't tested because of a denial, you know, that makes no sense to me whatsoever. So I feel very strongly that the testing should be done and the insurance companies should pay for it. That's just my 2 cents.
All right, I think we've run that issue to ground. The plan today is to discuss all these issues. I want to make sure everybody gets heard. Representative Bleier, go ahead.
Yeah, so my comment is on the sunset clause, Senator Sanborn. So I don't know if I agree with you 100%. I think that having a sunset clause for 2 years for the, bringing it back at the 131st legislature, which would probably be a new group. Further discussion could happen. We would have some kind of tracking of, how it all worked out. I think that, the comment was made that we could repeal the bill. I think for the most part, bills very rarely get repealed. They get more, mays turned to shalls or shalls turned to mays rather, and amplified more than repealed. And so having a sunset bill, I think, would be something that I would be in favor of. Also saying that, insurance companies made record profits last year. That may be so, but, by asking them to pay for more testing doesn't mean they're going to take less of a profit. I think it's just going to increase premiums. And so if we're focused on affordable healthcare for the people of Maine, that's a very important issue as well. So I think that, having this discussion 2 years from now, after the COVID, you're right, maybe it's going to be another year, maybe 2 years. But then we have a new legislature where we have a fresh set of eyes. We've already seen it with this committee where we passed bills unanimous last year. It didn't go through because we ended early, but we brought them back forward and there's been more discussion. So I think that that's important. So a sunset clause for me would be important. I would think that, through this legislative term, but bringing it back up through the 131st, I think would be important.
Are there other comments on this part of the analysis? All right, seeing none, I'm going to ask Colleen to pull her analysis back up so we can see what the next item on it is.
Yep. Okay, you guys see this? So
Yep.
I think we've talked about 1 and 2 generally, and we've also talked about the last one, but and I guess we've talked a little bit about number 3 as well, but this is how long to extend the testing and the scope of the testing. I don't know if you want to talk about the balance billing or the out-of-network provider treatment, or you want to talk about vaccinations, which was number 4.
Right. So let's pick up the balance billing piece because I suspect we all agree on that piece. This would just kind of be in my mind, it's the flip side of calling it an emergency. Oh, Colleen, can you go back up?
Oh, sorry.
So it's the flip side of calling it an out-of-network emergency service is to then add the no balance billing provision. And I kind of, in my mind, thought it was already in there. So it was certainly part of the intent when we drafted the sponsored amendment. But I'd love to hear any feedback from any other member of the committee about the balance billing provision. All right, seeing none, I'm going to assume that everybody's cool with prohibiting balance billing. So then there's a question about facility fees and administrative fees with regard to vaccinations. And we heard a lot of back and forth, I think, in the testimony just over the last couple of days about this. Just to frame up the issue, I think that the intent of the language, and this is the thing we want to try and capture in the final draft of the bill, but in my view, the intent of the language was, again, about protecting consumers from unexpected charges. So not about allowing providers to layer on extra charges, which, Colleen, does that make sense to you as far as like those two perspectives on it?
It does. So maybe it's just a matter of clarifying that, adding some more language to this. It's not a new fee. I don't know how I would do it, but I know what you mean. So if in normal circumstances, I mean, just to think about their objection related to administration of vaccines and facility fees, or the coverage for processing fees and clinical evaluations associated with immunizations. I mean, would you be getting at if it would be a cost that would normally be included, then it should be covered? Is that the kind of thing you're talking about?
Well, in my view, it should always be covered, but it should be subject to network agreements or this surprise, out of network emergency services, situation. So in other words, if you think the whole package of getting the vaccine was overbilled,
Yep.
then you need to deal with that either through your network contract or through
Through the dispute resolution.
the
Yep.
dispute resolution process, and you need to hold the consumer harmless. This is not
Yep.
intended to be a way for providers to upcharge things. It's intended to be a way to make sure consumers don't wind up with a bill that they didn't expect. And, you know, on the screening and testing situation, you know, we were really seeing a lot of those bills very early on, where urgent care facilities were charging for a full urgent care visit, the whole purpose of which was simply to administer a COVID test, and then insurers were denying that $300 visit. And this is when testing was much more limited than it is today. And it was difficult to get one if you didn't go to one of these urgent care facilities. So, you know, this is my concern, is that people are going to get unexpected charges that the insurer is going to say weren't part of the thing they were mandated to cover. So that's what I'm interested in protecting against.
So would there be situations, I don't know, I mean, I did note that immunizations, for instance, the way the bill is drafted, are not treated like an out-of-network provider bill for COVID-19 screening or testing. And so as the bill is drafted, they wouldn't be subject to sort of the reimbursement rate provisions and the IDR process. So are you suggesting maybe to treat bills for immunization in a similar manner, or
No, that feels
as one
too
way to
complex.
get at it, or not? That might be too much.
That feels too complex to me
much.
to deal with
Yep.
a $17 or a $40 bill, right? That's
Yep.
my issue, right? Is that I don't want to add complexity to the great work that Maine Health and Northern Light and Martins Point and Intramed, and I'm going to leave people out, but all of those medical systems are doing to stand up these mass vaccination clinics. And I don't think facility fees have been an issue, and the administrative fee is being paid for by insurance today and is mandated to be paid for by insurance by federal government regulations. So I guess it's just, you can't then add some other fee and call it something different so that you get to bill it directly to the consumer.
Okay.
And I don't know how to capture that in the language, but I
can
know
think
that's
about
the
that, but-
intent.
Yep. Okay. I got a note of that.
Does
Thank
anybody
you.
else want to weigh in on that particular issue? Okay. Seeing no hands up. Oh, Representative Morris, go ahead.
Yeah, I mean, I think I understand what you're after, and I would agree. We don't want this to be interpreted in any way that the consumer would have to pay more. And I certainly think we need to add some balanced billing, hold harmless piece to the language. We want to make sure that we don't give, you know, the providers an opportunity to say, well, we're going to charge you for this because the language says you have to pay it if we charge it to you. And so I think that that's kind of what I'm looking to, how I would want to see it amended, so that, like you said, it's a contract between the providers and the insurers, and try not to get too much into weighing into that discussion.
Yeah, it may be as simple as just adding it to our balanced billing provision.
Yep.
Right.
Yep.
Okay. Okay.
I think we're all on the same page. At least it's just, I'm not sure how to draft it, but I think we mean the same thing. Okay. Are
Okay.
those all the issues in section A?
I'm sorry, what was that? I missed that.
Were those all the issues in section
Oh.
A, part A?
No, there was the issues that were raised by the providers related to the notice provisions, and sort of the specificity around that, and whether or not you wanted to think about wordsmithing, as they suggested, taking out some of the specific requirements of the notice, like disclosing the total cost for the service and providing instructions for how individuals can submit claims. They suggested sort of taking those two pieces out and wordsmithing some of the other remaining paragraphs. And then also had suggested clarifying the language as drafted now. It says that providers may not charge uninsured individuals any amount for administering a COVID vaccine. and may not charge associated costs. And so they just wanted to clarify that that provision applied to uninsured patients only, about their ability to charge for those types of services. So there were those suggestions related to the
Okay.
notice piece.
So I definitely understood the issue around actually providing the forms for your particular insurer to submit online, but I think the idea of saying you can submit this directly to your insurer, you know, look on your insurer's website for information as to how, you know, I'm fine with making that change. Are there other comments on these issues? Yeah, so I thought that wordsmithing piece made sense to me. Representative Tepler?
Thank you, Madam Chair. I do want to note that, in my opinion, this was primarily about those organizations that weren't interested in processing people's insurance at all, but only those who were requiring a total upfront charge, not not just a copay, but an actual, please write a check for $400 before we give you a COVID test or a vaccine. And I know that at least early on in the pandemic, there were some organizations that were requiring upfront payment of actually a fairly large amount of money for testing. And they were providing no information to patients about the possibility of submitting it themselves to insurance companies. And so I think that some version of this is fairly important to prevent those organizations from putting people in a situation where they can't even use their insurance or don't understand that they can use their insurance.
Yeah, so I think
Yeah.
there is probably some wordsmithing that could be done in this section, Colleen.
Yep, I can definitely do that. Look at what they've suggested, and depending on what
Okay.
the next steps are, bring that back to you, or however you decide you want to proceed. I think the
Great.
last issue, really, I think you talked about the
We did.
sunset. I don't know if you came to any conclusion, but you've talked about it.
Yeah, great, thanks.
Yep.
Okay, let's go on to part B.
Part B, okay. So part B is the provision that relates to pharmacists and prescription drug coverage. There's a provision that authorizes pharmacists to administer and order COVID-19 vaccines licensed by the United States and recommended under emergency use authorization. There's also provision in Part B that would provide that advanced practice registered nurses with prescriptive authority, other providers who have prescriptive authority, doctors, podiatrists, and dentists may prescribe to a patient a prescription drug for an extended period of time, not to exceed 180 days during a state of emergency declared by the governor. So as I mentioned, this language would allow a prescriber to prescribe a prescription up to that length during a state of emergency declared by the governor. The way it's drafted, it would apply to any state of emergency, including the current emergency, as long as the governor continues to extend that declaration, and any state of emergency that would be declared in the future. So one suggestion was made as to whether or not the committee would limit the scope of the authority to this current COVID-19 emergency. It is an authorization, so it's not a requirement that prescribers prescribe prescriptions up to the 180-day supply, but it does authorize it. The bill does provide an exception for opioids that are prescribed in accordance with existing limitations and current laws. There are limits on the length of prescriptions for opioids, and the bill recognizes that. So says that a prescriber can prescribe prescription drugs up to 180 days, except for opioids. And there's also an exception for instances where prescriptions would be inconsistent of such length would be inconsistent with public safety or contrary to the applicable standards of care. You did have some suggestion and testimony from Maine Health that the phrase contrary to the applicable standards of care be removed. I see a hand. I'm happy to stop as we go along if you want me to do that.
Representative Tepler, go ahead.
Thank you, Madam Chair, and thanks, Colleen. I just want to chime in here that I mean, one of the things about this pandemic is that hopefully we're also learning lessons for the future and to be more prepared for situations in which there are emergencies. And I guess I feel that any state of emergency is a time when someone might need to keep around a larger supply of their necessary drugs, whether that emergency is weather related or otherwise, because it might be a time when the drugs might not be coming through the state as regularly, because it might be a disruption to your ability to get transportation or get to your pharmacy. So, you know, I think of it as part of sort of our capacity, preparedness, and resilience response to what we learned from this pandemic.
The language as drafted does require that the governor have to declare an emergency for it to be to have the authority. So I just wanted to clarify that. So there would have to be a declaration under the emergency powers. The way it's drafted now, it could certainly be changed.
No, I'm comfortable with it being that kind of an emergency, you know, where it's serious enough that the governor would have to declare emergency powers.
So, Colleen, why don't you finish going through this, and then I have some questions.
Great. Okay. As I mentioned, the bill authorizes up to a maximum length of a prescription of 180 days. You did have some suggestions that by representatives of carriers and others that you consider 90 days, which is more in line with how some of the mail order prescriptions, for instance, have been used and developed during the pandemic. And there also have been some authorizations and requirements at the federal level, allowing Medicare beneficiaries, for instance, to get prescriptions of up to 90 days. Northern Light Health suggested in their testimony that it should be clarified that if prescriptions were made under these circumstances and under these sections, that there'd be language requiring carriers to provide coverage for prescriptions for the length of up to 180 days. It was also suggested in the testimony received from the Retail Association of Maine that you consider clarifying the language, both that there's authority to prescribe and to dispense prescriptions in a 180-day supply. And then lastly, the Retail Association of Maine suggested in the provision that gives pharmacists specific authority to administer COVID-19 vaccines, that they be, you add a reference to billing for those vaccines, and also add specific language authorizing pharmacists to delegate their authority to administer vaccines to pharmacy technicians and pharmacy interns that would be under the supervision and control of the pharmacist. I think that was it. Yep, there were just 5 for this section.
Okay, so I think it would be helpful. Representative Bleier, you could go ahead first.
Thank you, Madam Chair. So, I agree with Representative Tepler. I do find an issue with the 180 days. That's a long time. I mean, if it's January 15th, you're looking, you know, past 4th of July. And so I'm not 100% against it. I just feel that could be problematic. 180 days worth of medication could be a lot of, lost medication, a lot of waste that could come along with that. So those are some of the concerns that I have. I think the 90 days with maybe an issuance of an additional 90 days, I think we'd be more in line So I just feel like 180 days is a very long time. So I just have some.
Thank you, Representative Bleier. So I'm going to ask if there are any attendees. So the thing I'm puzzled with about this section is what the non-pandemic, non-emergency rules are or laws are, because this section, Part B, amends a bunch of licensing statutes. And I don't understand in practical terms what the current state of play is, not current, but the pre-pandemic state of play was with regard to length of prescriptions. You know, certainly with regard to contraceptives, a year-long prescription is authorized and normal and the way it's done. And I understand that there are certain other conditions. Representative Evans mentioned ulcerative colitis, where a year-long prescription would be quite normal. So I'm wondering if there's anyone sitting in our attendee pool who might be able to speak to that at all. I was thinking Ms. Harvey McPherson might be able to give us some thoughts on that. If you would raise your hand, Ms. Harvey McPherson, if you can give us insight on that, that would be great. But I'm
or any pharmacy representatives.
no, I don't see pharmacy people, but this is almost more of a prescriber question as opposed to a pharmacist question. Ms. Harvey McPherson raised her hand, so hopefully she can help me understand this a little bit better. Christian, would you bring her into the meeting?
May I?
Representative Tepler, go ahead. I couldn't see your hand. It's black. It's very dark against your dark background with your camera off.
Yeah. Thank you. I'll turn my camera on. Maybe that will help. But just really quickly before Ms. Harvey McPherson gives us sort of a professional opinion, as a patient who takes a lot of medication, I already have 90-day dispensed prescriptions. I already do for my normal regular prescriptions. So 180 days, and that's dispensed. My prescription from my doctor lasts a year usually. But
yeah, so yeah, that's exactly what I'm trying to understand is why is this provision in the bill at all? Like, what does it do? What does it change?
It's a question of dispensing, I believe, and having insurers cover 180 days dispensed, so that I would have a very large quantity of my medication at home. I wouldn't have to make trips to the pharmacy, and it's only for medications that aren't going to cause a problem, I would say. They're medications that you rely on to keep yourself healthy.
Okay, as drafted though, it's a provision, a set of provisions that amend the licensing statutes.
Yeah.
So that's exactly why I'm asking this question, because I think we might be changing the wrong law or doing the wrong thing. So,
and I think the suggestion to add the word dispensing is part of why they've made that suggestion to the language. That's my understanding.
Okay, Ms. Harvey McPherson, go ahead.
So I will try to help. I don't know the answer to the licensing piece, and I can look that up. But when we worked on this section, the provider feedback was the providers would not, issue a 180-day prescription for any new prescription. As Representative Tepler talked about, it's an established patient with that provider or that provider group with an established medication protocol that is stable and the patient is stable. And when we thought about 180 days, what we thought about was the issue of the patients that don't have mail order, and with the protocols around individuals not, perhaps older adults at risk, not wanting to go to their pharmacy to be exposed, that having a longer period of medication would allow them to quarantine, or not officially quarantine, but stay at home for a longer period during a pandemic, which is what we're in. So that was our thinking.
Okay. So Representative Evans, go ahead.
No, what I was going to say, on average, the normal prescription would be for about 90 days, a 3-month supply.
Mhm. Yeah. And
Okay.
we didn't have a sense that this would be a high volume ask, but there may be situations for individuals who don't have mail order, who want to stay out of kind of public settings during a risk period of risk, that if they're stable and their medications are stable, that this might be an option that a provider could choose to access. But I didn't get the sense from talking with our doctors that it would be a significant volume of patients.
Okay. Colleen, I feel like prior to our next work session, which is Thursday on this, I need to understand better why this is in the licensing provision. Because just experientially, I would think our prescribers have the capability of writing 1-year prescriptions, 180-day prescription, whatever is appropriate medically, and that this might be more about dispensing, in which case it doesn't need to be in all of the prescriber licensing statutes, which it is right now. It just needs to be in the dispensing statute or in the pharmacist provision. But I want to make sure I'm right on that, because a lot of eyes have seen this draft and not called that out.
I could double check.
So
with
I
that.
don't,
Yeah.
I
double
don't
check
know
on
who to
that.
talk to about that, but
Yeah. I could reach out to some of the licensing boards to see if there's anything. There's nothing in statute that I think would prohibit it, but there's nothing that specifically authorizes it either. But there may be something in rule or in standards of, you know, standards of care or something that folks thought that there needed to be some specific statutory authorization for it for each category of prescriber. So I'll double check.
I wouldn't want somebody 10 years from now to look at this statute when there's another state of emergency and think that it means that you can only get 180 days of your contraceptive supply, for example.
Yep.
Right? It could be read backwards if it is in the wrong spot or is not correctly dealt with.
Yeah.
Representative Tepler, go ahead.
Thank you. I mean, to the best of my knowledge, all of my stable, regular prescriptions are 1-year prescriptions, and they need to be renewed with my prescriber, with the provider after a year. But dispensing, most of them are dispensed in 90-day amounts. So it is really, I think the issue here is not about providers writing prescriptions. It's about whether or not pharmacists have permission to dispense 180 days and whether or not insurers will cover the 180
That's right.
That's
That's
what
right.
I think too.
I think that's right. But again, we need to get this right. Representative Quint, go ahead.
I just had one question because I work in people with disabilities, home providers, and they actually have to have their doctor's orders renewed every 6 months. So with the way that works out, if they were in an in-between period where it expired within 3 months, say they're halfway through that 6-month period, they could not get a 180-day supply. If that went through, I just think maybe that wording would need to be looked at, because that's state mandate already, that has to be reviewed every 6 months. And so I'm just a little curious, not to throw another log in there, but just making sure, because if they went to go get those prescriptions, then either they wouldn't be eligible or it would kick back. So just maybe finding out about that as well. I don't know if that's something Colleen can find out, but that's for shared living providers that statute exists. Thank you.
Shared living providers. Okay, thanks for that piece of information, Representative Quint. Representative Tepler.
Thank you, Madam Chair. And I believe that there are certain categories of medication that you can only get a 6-month prescription for, like psychotropic medications. So it's not, and perhaps those would come under the category of things that would not actually fall in this law. So I don't know, maybe Ms. Harvey McPherson can kind of speak to that.
I'll be glad to talk with Acadia about that.
I mean,
Okay.
the language as
Thank you.
drafted does try to provide some exceptions, but it may not be, but it's broad. It's not specific to type of medication, but
And then
we can talk.
Representative Evans, did you want to weigh in? All right, I think he's frozen.
No, I was just going to say DEA consideration, depending on what type of medication, different classes.
Right. Right.
As
Although opioids have already been carved out of the bill. So,
yeah, but there are
okay. There are other
others
regulated
still.
narcotics, sure.
Yeah.
Okay.
And another class of drugs would, I just wanted
let me time out. I just, if you want to be recognized, could you please raise your hand? Sorry. Thanks. Representative Arford, did you want to weigh in?
I just was going to say that there are like drugs to treat attention deficit disorder, controlled substances that have to be renewed every 30 days, but we're going to be looking into the different classes, correct?
Yep. I think we've got Colleen's work cut out for her on this particular section of the bill. It's a quick turnaround, but I think we'll see how far we can get by Thursday. And thank you very much, Ms. Harvey McPherson, for jumping in and allowing us to ask you those questions, which are perhaps not totally in your wheelhouse, but we always appreciate the input.
Thank you.
Okay. Colleen, do you have enough information about what we need to continue working on this section?
I think so. I just want to ask about the suggestion about clarifying the authority for pharmacists to both administer, order, and bill for administration of vaccines, and then the language that they had suggested authorizing specific delegation to pharmacy techs and interns. So that's another one that's sort of separate from this issue about how long a prescription can be issued. It goes more to the vaccination. That's just put a pin in it for now, for either now or later. But.
Yeah, I mean, I think with regard to charging of the billing an insurer, I would expect that they would be able to do so on even playing field with other types of clinics. So Walgreens is doing a vaccine clinic. I would expect them to be able to write the same bill as Northern Light Health to go forward with that. So I think that makes sense. And we're going to have a bill coming up soon that would make clear that that's always kind of allowed. But this, I think could be a clarification that we could put into LD1. Is there anyone else who has a comment on that billing question? Okay. With regard to the interns and tax question, I need to get more information because that language has been in and out of the bill in a couple of different drafts, and I'm not sure why. So I need to know more about why. So if there's someone listening to the Zoom or attending the Zoom who wants to just shoot us a note, shoot Colleen a note in the interim before our next work session to let us know why it was taken back out of some of the interim drafts here, that would be great.
Okay.
I think it has to do with Federal PrEP Act stuff, and I don't totally understand that. So
I think it might, and then there's the Part D is specific to the point of vaccination sites, so they would be covered in those settings, but not all settings. Yeah. Okay.
Right. Representative Morris, go ahead.
Yes, thank you, Madam Chair. I guess, I think along that line, I guess I'd be interested to know if they generally are able to dispense vaccines or not. I guess that's my question on that issue.
Like flu vaccines and those other types of vaccines that pharmacies tend to give. Yeah. Mm-hmm.
Yeah.
Okay.
Yes.
Yeah.
There is current law that authorizes that, and the language in LD1 tracks the existing law that authorizes pharmacists to administer certain vaccines. So, but I can provide more information at the next work session about that, so you can see that it tracks the current. It attempts to track the current provisions statute for other vaccines.
Okay. Good. Let's go on to the next section.
Okay, so after part B is part C. And part C relates to making changes to the current requirements in the insurance code related to telehealth services.
Okay.
Part C would remove the restriction on telehealth by audio-only telephone and also makes payment parity, specifically provides for payment parity for those services. You do
I'm
have
going
some
to
other
interrupt
bills.
you, Colleen.
Yeah.
Yeah, so there are a number of other bills on telehealth
There are.
that we have not heard, and we haven't had a separate hearing on telehealth. Obviously, folks weighed in on the telehealth provision, but I want to suggest to the committee and take, rather than having Colleen walk through her analysis on this section, I want to suggest to the committee that we take this piece of LD1 out of LD1, and with the intention of passing a bill this session on an emergency basis to deal with telehealth, but to make sure that we're doing so with a little bit more fulsome consideration of our various options and the risks and benefits of each one. So any committee comment on that that concept of excising telehealth? Representative Morris.
I think that makes perfect sense. I'm in full agreement.
Great. All right. Any other comment on telehealth being a standalone bill? All right, great. Then we can skip part C and move on. Thank you.
So the last part of the proposal is part D, and this language would allow delegation of authority by an on-site clinician to certain persons to administer COVID vaccines as part of point of dispensing vaccine sites set up with a memorandum of understanding with the State Department of Health and Human Services. The sponsor has suggested 2 additional technical amendments to the language that was originally proposed to the committee, further clarifying that any on-site clinician in charge at a point of dispensing vaccine site that has an MOU with DHHS may delegate authority to administer vaccines, and then further clarifying the language that the provisions apply to the current COVID-19 emergency declared by the governor. These next 2 issues were some suggestions or concerns raised by Northern Light Health. It's my understanding that those concerns have now been assuaged, and Northern Light Health is comfortable with the language as written. Perhaps Ms. Harvey McPherson can confirm that after, but that's my understanding about making further changes to the language in Part D. There was some suggestions from representatives that you think about encouraging federal funding to cover costs of vaccines administered to uninsured persons. There is some available federal funding that would allow providers to get reimbursed for vaccines that are administered to uninsured people through CARES Act funding and other grant funding. It was suggested that perhaps you could consider adding some specific language. I'm not so sure that would be necessary to add to the bill, but it's something that was suggested. And then insurance carriers also raised some concerns about the requirement right now is that they're not currently required to cover administration fees associated with these types of vaccination sites. So that's something else to consider as part of their testimony. And then just generally, I did link here to a recent press release, and Representative Morris raised that there was some recent guidance that was issued by CMS last week, updating some of the frequently asked questions and related to the requirements for health insurance issuers in the individual and group markets to cover COVID-19 testing and qualifying preventive services like vaccines without cost sharing or prior authorization. There are some sort of interim rules and regulations and also a lot of FAQs. And so this link will take you to the recent press release, but within that press release, there's lots of links to the specific federal regulations and also the guidance that's been issued along the way by the federal government on this issue. I just wanted to point that out to you as additional information if you wanted to look that over before we come back on Thursday.
Colleen, I have a question about number 5.
Yep.
My understanding is that health insurance carriers are absolutely covering administration fees right now. I mean, if administration fee means the cost to administer the vaccine, I mean, an awful lot of online time is being spent by a lot of people inputting their insurance information, presumably so that our vaccine clinics can bill the cost of administration to the insurers. What am I missing?
Yeah, I think it was my understanding, and we did receive some additional testimony that came in today that might flesh this out. So this was just part of the note taking, but I'm looking quickly at the and Miss Austin Fort was the one who sort of raised this issue and has talked about it. I think it relates to the specifics of the point of vaccination sites, as I understand it. And I don't know if you want to have her weigh in, or I can provide, I can share that additional testimony that it came in this afternoon. So right before you started, so I don't have more details. It also might, I think, relates to the PrEP Act issue that you raised earlier, Senator Sam.
Okay. Why don't I promote Miss Austin Fort? She raised her hand, so I'm just going to promote her into the meeting.
Stop sharing.
And you can stop sharing.
Yeah.
And she'll be here in a second.
Did you promote her? Okay, great.
I did, yeah.
Great.
So we can ask her that question, because I was really baffled by that piece of it. Good afternoon, Miss Austin Fort.
Good afternoon, Senator Sanborn and members of the committee. Thank you for the opportunity to address that. I think there's, it's a little bit of words too close to each other. We do pay for administration of the vaccine. I think the concern is similar to what you discussed earlier about the language for administrative and facility fees being added on, because Part D does have the provision to allow for the charging of administrative and facility fees, which is a little bit different than the fee for administration of the vaccine, which is the actual shot in the arm that they get reimbursed for. So it's the same concern that you covered earlier in your discussion of facility fees.
Okay. And I mean, but in thinking about the cost of putting a shot into someone's arm, the cost isn't just, you know, the moment when you're jabbing somebody, but some amount of the overhead for the facility and the check-in process and the online sign-up process. I mean, those are administrative things, but all of our healthcare system has administrative things, and those get baked into the cost of the actual shot in the arm generally. But our concern is when they get split apart and then the insurer denies coverage of one of the parts, and then the patient is left with a bill. Am I explaining that correctly, Ms. Austin-Fort?
I think I understand what you're saying. I mean, they shouldn't be split apart because, and you know, for example, there aren't administrative fees for administration of the flu vaccine. So you're creating sort of an add-on fee for COVID that doesn't exist with respect to other immunizations. And that's where our concern is that there are costs associated with that.
Okay. I think we need to be clearer about what we mean by a cost to administer the vaccine. I think that's really all we're talking about, but it has to be the whole cost that is billed, no matter what they call the cost. I think that's what we're trying to get at.
Absolutely. And if it's an in-network provider and we have an established reimbursement rate, they have to accept that. They can't then turn around and balance bill the patient for the remainder.
Right. Right. But we don't have to put that in the law because that's already the law. Right. Okay. Okay. I think, Colleen, with regard to facility fees and administrative fees, I think that's maybe the key to how we get to this, is that the cost to administer the test or the cost to administer the vaccine has to be the thing that is billed. And you got to bake your overhead into that. Mr. Austin wants to weigh in though, so perhaps I've gotten it wrong. So I will, I'm going to let Ms. Austin-Fort hang out with us as well. And I'm going to promote Mr. Austin to a panelist in the interest of fairness. This is why we run our committee room the way that we do on work session days. So welcome, Mr. Austin. I apologize for the dogs singing in the background. It's dinner time here at my parents' house. So, so Mr. Austin, tell me what I've said wrong.
I don't know that you said anything wrong, Senator. I will try to be very quick. Jeff Austin with the Hospital Association, and I'll have to check with some of my members. I think there's a couple of things here. We didn't negotiate this issue in 2019. We didn't know it was coming. So we're dealing with something that's maybe a little different than the normal annual school-based flu vaccination clinic. The registration process, the fact that there has to be a follow-up shot within 3 weeks, the 15 minutes monitoring for allergic reactions. There's a whole lot of stuff administratively going on, not just the physical administration of the nurse administering the shot, monitoring you, giving you your Band-Aid and all that. But there is administrative costs, overhead costs associated with setting up these clinics that are pretty significant, that are not like first come, first serve flu clinics at your kid's school, where they're not. We have to report reams of this data to both state and federal government daily. That's not true with the flu clinic. So all of that is overhead administrative costs. I'm not sure how much is built into the giving of the shot. So I need to ask about that. I wouldn't necessarily presume it. A lot of the ways hospitals get all those overhead costs is through what we call the facility fee. Whether you bake it into the cost of the service or you segregate it out as a facility fee almost doesn't matter. I think that's Senator Sanborn's point. It should be paid for once, not multiple times. I just don't know that the administration, the shot cost, is capturing the administrative costs that are much more significant here than in the annual flu shot. And since we didn't really negotiate it because it hit us in early 2020, I just need to find out. I don't know the answer to the question, and I will try.
Thanks for that feedback. Representative Tepler, I see you. Go ahead.
Thank you, Madam Chair. And thank you, Mr. Austin, for being here. I guess one question I have is, I thought there were designated federal funds for some of those expenses in setting up the clinics.
I have to look into that too. I believe the state has received funding. I don't believe providers have received direct funding. I think there are some FEMA reimbursement systems available where after the fact, we're going to be able to apply for reimbursement. But let me try to get a clear, accurate answer rather than guessing.
Thank you.
And Ms. Harvey McPherson's going to know the answer to that question. So Representative Matheson, before I let you go, I'm going to bring Ms. Harvey McPherson in as well. This is like old school work session time here. So we will have the whole panoply here because Ms. Harvey McPherson, I think, has been directly involved in these MOUs with the state. So can you help us understand how the federal funds are flowing and how the overhead is working?
Yeah. So as of today, Northern Light Health has not received any funding for standing up all of the vaccine clinics. We do bill commercial carriers and Medicare and Main Care an administration fee, but we are not billing a facility fee. So we have cost analysis teams that are tracking all of these COVID vaccine related costs. And we have consultants that we're working with to try and access funding from FEMA. The December package that passed in Congress did allocate to Maine funding for vaccines, and I believe it was $12 million. And thus far, the administration, I think, hasn't decided exactly how all of that funding will be allocated. And of course, the COVID package that's being discussed now in the Senate has additional funding for vaccines. So that's all very much in play right now. I think the intent, if we were to receive funding, is this is a massive project. The technology that is even behind all of these centers, let alone the website, but the technology at the centers, as one example, is a significant investment. So we're tracking all those costs, and some level of federal resource should offset those costs for us and for Maine Health and all the clinics that are being stood up.
Representative Matheson, you're next.
Thank you so much. That was really helpful, Mrs. McPherson. Are you, in your analysis, are you putting information in about main responders and all of that volunteer work? Because I know at the York County level, there's a significant volunteer response that's being involved in the vaccination distribution. So I'm just wondering if that's going into the calculations too.
Yeah, so for Northern Light Health, we track our expenses, and we have employees that volunteer time. For example, I'm a nurse, and so I volunteer on the weekend at our COVID vaccine clinics because they needed nurses, and all of that time is donated and tracked.
Representative Evans, go ahead.
I just wanted to ask, we were talking about an administration fee, and are we bundling things together, an administration fee and a facility fee? What's the goal?
Ms. Harvey McPherson, go ahead.
So, I think the fees honestly are set off the Medicare rate, and Medicare says, I'm going to pay you X amount to administer the first shot, and I'm going to pay you Y amount to administer the second shot. I think the whole fee schedule is built off that.
Okay. This has been super helpful. Are there additional questions? Representative Quint.
Yes, I think this might be for Lisa Harvey McPherson, where she was just saying the individual immunizations, there was a set price to it. Now, if there's a set price, but they're also adding all of the administrative costs above that, is that correct? So is there any sort of a cap at all that we have with other charges that are given?
We're not fully loading the administrative charge to administer the vaccine. That's not a fully loaded charge. So all of that back end costs that I talked about in standing up these clinics, that I believe is what the intent of the federal funding and FEMA funding is supposed to offset.
Representative Quint, go ahead.
And so if insurance companies are actually paying out on this, then will they be compensated or recompensated for what they've spent for that up until that point?
It hasn't been billed, I think. Ms. Harvey McPherson, is that correct that it hasn't been billed? You're collecting the cost data, but you're not billing it out.
There's two things. There's billing the insurance company for a clinical service, which is giving the shot, and there's a fee associated with that. Then there's the cost to the provider that is standing up the public health infrastructure to offer vaccine clinics to Maine's population. That's the cost that we're tracking to offset with federal resources. But we're billing that clinical service to the carriers.
Yep. That's really, really helpful clarification, and I think is much, much clearer. I think we're going to be able to make clear what we mean about regulating the insurers to ensure the whole bill gets paid for. And I think that's really the intent, but not to also make the insurers pay for the whole cost of standing up the clinic, because that's not the intent either. So, but I think this is very helpful because I think we all know what we mean. So it's going to make for better law when we get to that place. Representative Arford. Unmute for me.
I am going to get the not unmute award at the end of this session. So I just want to make sure I'm getting this so I don't have to ask this question ever again. So there is a administrative fee being assessed and charged to the insurance company. And it's like $24, $18, $12. And that's the fee that actually pays to get the shot delivered in the arm. Is that correct? But there is no facility fee whatsoever being charged. However, at some point, the providers may get reimbursed from the federal government for providing the facility and everything else that it's taken to set up these clinics.
That's right.
Correct. And I want to be clear, I speak for Northern Light Health, so we are not billing a facility fee. And I don't think anyone else is, but I just want to make sure that I'm very clear about that.
Right.
But the intent of the federal resources
Right.
is to help offset
Exactly.
that infrastructure cost, which is significant.
That's a hope.
It all makes sense.
That's a hope. Yeah.
Right. We'll keep our fingers crossed for sure, Mr. Austin. But yeah, that's certainly the intent. Okay. Are there additional conversation around this section on Part D? Ms. Harvey McPherson, while we have you here, you had asked for, I think, a more explicit list of the types of providers we had in mind for delegation, but then Ms. McCarthy-Reed suggested that you had been satisfied to not have that. So can you give us your thoughts on that?
Yeah, I worked with Bethany in the governor's office, and the intent of drafting this section was to align this section with the PrEP Act. And the PrEP Act continues to be amended to allow more flexibilities. So they wanted to be flexible in this language, but understand that a entity that has an MOU with the state that allows delegation can be more strict. And so we may be more strict that it must be a doctor or a nurse volunteer, for example. But this language is broader than that, and it's intended to more closely align with the federal flexibilities. And that's the same with the section I commented on tracking training information. They wanted to align with the PrEP Act for the protections that the PrEP Act provides and bring that language as closely as they could into this. And I understood that, and that made sense.
Okay, great. That's always good when we're on the same page with those folks. Anybody have any other topics that we should talk about with regard to LD1 at this stage? Obviously, we are not going to be voting on LD1 today. That was never the intention. It's a big bill. So our hope is to vote on it on Thursday. We have our work cut out for us on that, but that is still the goal with us going into session next week. So so we'll work really hard on it and try and get to that place. Please feel free to reach out to the various folks in the next couple of days who might be able to help you, answer questions that might be lingering, and get the information that you need in order for us to try and go forward on Thursday. Anybody have any last words or comments on LD1? All right, seeing none, I'm ready to entertain a motion to table. Representative Quint, go ahead.
I make a motion to table LD1.
Thank you, Representative Quint. Can I have a second? Representative Evans, I see your second. Excellent. So it's been moved and seconded to table LD1. My dog agrees. So all those in favor, please raise your hands. Okay, so it's unanimous of those present to table LD1, and we plan to pick it back up on Thursday. And we've got just about 15 minutes before 5 o'clock here, and I think we've got some language review to do. Colleen, is that right?
Yep, just one quickly language review in hopes that we can move this forward so you can consider it next week. This is LD 60, which the committee already voted on. Oh, and I don't have it. Let me see if I have it pulled up. Sorry, I thought I had it pulled up. Let me see if I've got it there. I'm going to get it quickly pulled up here for you. Sorry about that.
That's fine. Take your time.
I thought I had it already there, but I don't. So you had already reviewed this amendment, but we did not yet have the fiscal information when you approved the language of the amendment. This is LD 60, which was an act to clarify the minimum amount of emergency refills of insulin. And the revisor's office has prepared the amendment. So I've given you sort of their final draft to review. You had voted to add an emergency preamble and an emergency clause to it, and had looked at that language. So that is here for you. and then also clarified the language that the quantity that must be dispensed must be at least the 30-day supply unless the intended recipient requests a lesser quantity upon consultation with the pharmacist. Then we also required some notice, which you had looked at that language last time as well. And then there is some additional clarification that the Board of Pharmacy would establish protocols in their rules for how the notice would be provided. So that's the language that you had looked at, but you hadn't yet seen the fiscal information, and the rules, joint rules require that before anything gets reported out of committee, you have to see it all. So I just wanted to make sure you saw the fiscal note, which will be added to the bill, which just recognizes that any additional costs to the Board of Pharmacy to implement the requirements of the legislation, if enacted, can be absorbed within their existing budget. So that was it.
Great. Does anybody on the committee have any comments? All right, seeing none, I think that's the end of our work for today. Is that right, Colleen?
That's all I had for everyone.
Okay.
We'll come back on Thursday. If anyone has any more follow-up related to the budget hearing or wants some more information for the work session, we were going to try to start that on Thursday as well, because we have a report back date of the 12th, and we only have one day next week in committee to meet, which is the 9th. So let me know by email or give me a call if you have any follow-up on that. I'll try to get the information related to LD1 for you as well. And we'll meet at 10 with a report back from MHGO. And so hopefully you'll be able to get that additional information from them as well about LD 274 on Thursday. So the timing all worked well for that.
Great. Okay.
That's it.
Excellent. Perfect. I think that's everything then. So have a wonderful evening, guys, and